The next speaker, Professor Filippo Crea, Professor of Cardiology, Catholic University and Policlinico Gemelli, Rome. Clinical phenotypes of ischemic heart disease.
Thank you, Leo, for this second opportunity. And this is the first phenotype. All starts with a cigarette and a Big Mac. And indeed, we know, as shown in this brilliant study published by Salim Yusuf, that 8 risk factors account for about 90% of myocardial infarctions. This means that myocardial infarction is really an environmental disease where we are able to abolish these 8 risk factors from childhood. We might wipe out cardiovascular disease from the face of Earth. Interestingly, some of these risk factors are in risk charts: hypertension, diabetes, dyslipidemia, and smoking. But 4 risk factors are not in risk charts, but they are similarly important, including abdominal obesity, psychosocial factors, irregular consumption of fruit and vegetables, and a sedentary life. And altogether, these 8 risk factors are devastating. If all risk factors are present, the probability of myocardial infarction is 500 times higher compared to patients without any risk factor. This is why primary prevention is extremely important, including lipid modification, glucose lowering, blood pressure lowering, and also, very importantly, lifestyle intervention, because 50% of myocardial infarctions is explained entirely by a wrong lifestyle. Addressing, in this case, it is important to address smoking, abdominal obesity, psychosocial factors, depression in particular, irregular consumption of fruit and vegetables, and a sedentary life. Now, if we fail with primary prevention, then we have the real first phenotype, which is angina. Now, what we have been learning in the past few years is that stable angina is a phenotype with 3 different mechanisms. And in these recent guidelines published by the European Society of Cardiology, for the first time in guidelines, we consider 3 clinical presentations of stable angina, which are microvascular angina, vasospastic angina, and stable angina caused by epicardial stenosis. By now, you know everything about microvascular angina. I remind you that the mechanism is complex because many things can go wrong in coronary microcirculation at the site of endothelial cells and also at the site of smooth muscle cells, which tend to be neglected. Mechanism of microvascular angina are mainly 3: enhanced response to vasoconstrictor stimuli, impairment of dilatory function, and also some of these patients have enhanced pain perception. This is a typical example of microvascular angina. You can see no epicardial stenosis, but during angiography, during acetylcholine testing, these patients develop severe ischemic changes, severe pain, but no spasm, no stenosis, but symptoms are there, and after nitrates, DCG goes back to control, and the pain goes. Another mechanism of microvascular angina is impaired dilation, and this can be highlighted by drugs like dipridamol or adenosine, which dilate microcirculation and bring up this mechanism. This is a lady, you can see again normal coronary arteries, normal baseline ECG, but during infusion of administration of adenosine, this lady develops severe depression and severe pain. This is a second mechanism of microvascular angina. And then we have vasospastic angina. This is not frequent, it's less frequent than microvascular angina, but still important, and you can see no obstructive stenosis and then coronary spasm. We know that coronary spasm is caused by constrictor stimuli acting on smooth muscle cell which are hyperreactive to constrictor stimuli. The combination causes spasm. Several substances can cause constriction, and smooth muscle cell hyperreactivity is related to many post-receptor alterations, and in particular, recent studies show that Rho kinase hyperreactivity is an important molecular mechanism responsible for smooth muscle cell hyperreactivity. And then we have stable angina, the traditional stable angina, caused by epicardial stenosis. But in this setting also, microvascular dysfunction can be important, and this is suggested by the observation that PCI, that stent implantation, doesn't improve the outcome of these patients. This is a very recent meta-analysis in more than 5,000 patients, and you can see this is optimal medical therapy versus optimal medical therapy plus stenting, and this doesn't improve mortality, doesn't improve non-fatal MI, doesn't improve unplanned revascularization, but interestingly, doesn't improve angina. Angina is still there after stent implantation. On average, stent implantation doesn't improve, not even angina, suggesting that type 3 coronary microvascular dysfunction can be important also in this setting. If we fail with primary prevention and with control of stable angina, then the patient can develop myocardial infarction. And sometimes the transition from risk factors to myocardial infarction is direct. Now, this transition from the stable plaque to the unstable plaque is much more complex than we thought before. This is an old study, but very interesting. This is the percentage of coronary arteries, it's a post-mortem study, percentage of coronary arteries covered by atheroma according to age in patients who died of coronary death, of heart attack. And you can see that in some patients, the heart attack took place at the age of 40, when only 20% of the arteries were covered by atheroma. In other patients, in other cases, patients reached the age of 70, when all the arteries were covered by atheroma before dying. But even more interesting is that in patients who died of non-cardiac death, you can see again that atheroma is there. And some patients can reach the age of 70, all the arteries are covered by atheroma, and they die of non-cardiac death. So the relation between atheroma and the acute, the fatal event, is very, very elusive, as you can see. Only few atheromas in few patients at certain point in time become unstable. The only interesting clinical observation in this study is that none of the patients who died of coronary death had zero atheroma. This is why prevention is very important, because if with prevention we completely stop the progression towards the atheroma, then the patient will not develop myocardial infarction. But once the atheroma is there, well, the phenotype is myocardial infarction, but again, as with angina, we can have different underlying causes. And nowadays, we tend to treat ischemia, necrosis, and thrombus, which is the last common pathway. But the real question, the open question, the $1 million question in this field is what causes necrosis and thrombus formation. And with OCT, this wonderful microscope, we can have now in the coronary circulation in our patients with the resolution of 20 micron, we are discovering a new world. This is an OCT image in a patient with an acute infarction. We are within the coronary artery. This is a cross-section as it is seen with OCT. And here you can see plaque fissure characterized by plaque inflammation. And this is one, it's not an endotype, Professor Chang, but we're on the way to the endotype from the phenotype. In this case, the mechanism of infarction is plaque fissure of an inflamed plaque. But we can also have plaque fissure, as in this case, without any inflammation. And we have erosion. In this case, there is no fissure, but the thrombus is there, which can kill the patient. And in some patients, we have a smooth plaque. And therefore, At the center, we have ischemia, necrosis, and thrombus, but we have different pathways which can reach there, including plaque fissure with inflammation, plaque fissure without inflammation, plaque erosion, and a smooth plaque, and in this case, functional alterations involving epicardial vessels and microcirculation are the mechanism of disease. This is a recent classification we have proposed with Giovanna Liuzzo, which perhaps represents the frame to consider new therapeutic opportunities, because our only target these days is thrombus. But according to this different mechanism which can lead to thrombus formation and acute syndrome, we can consider different forms, personalized forms of treatment according to mechanism of disease, because in patients with plaque fissure, with inflammation, we need anti-inflammatory drugs. If there's no inflammation, the issue is plaque stabilization. In plaque erosion, perhaps we have to push more our luck with antithrombotic treatments. And if the problem is a smooth plaque and functional alterations, we need vasodilators. You can see different forms of treatment for this different underlying mechanism of disease, all leading to the phenotype of myocardial infarction. If we fail with the prevention and treatment of myocardial infarction, then the patient develops a new phenotype, which is heart failure. And sometimes the transition from risk factors to this phenotype is direct. I don't have time, of course, to go into detail of heart failure, but this is a very interesting classification proposed some time ago by the American Heart Association in 4 stages, in which, and this slide summarizes the impressive progression we have made in this field in the last 20 years. Stage A is the symptomatic patient with a normal heart, and here the issue is really prevention, primary prevention of heart failure by addressing risk factors. Then we have stage B, where we have LV dysfunction but no symptoms. This is very interesting because at this stage the patient is asymptomatic, but ACE inhibitors and beta blockers improve the outcome. And then we have stage C, where we have structural heart disease and symptoms. And in this case, again, ACE inhibitors and beta blockers improve the outcome. But in this setting, also anti-aldosterone drugs improve the outcome, and also ICD, if ejection fraction is less than 30–40%, and resynchronization treatment if the QRS is prolonged. Loop diuretics do not improve the outcome, but may improve symptoms, and at this stage, a multidisciplinary approach is very important. And then we have stage D, which is the most severe, the most advanced stage of disease, and at this stage, LVAD and transplantation are options to consider. What about the future? Well, the interest in stem cells is always very, very high, although we don't have any evidence that they are ready for clinical applications, but in particular, cardiac stem cells are very interesting. This is an early study published some time ago in The Lancet, the SCIPIO trial. Patients were with stable chronic heart failure who were randomized to placebo or implantation of their own cardiac stem cells with some interesting improvement in ejection fraction over time. So here we have many opportunities to prevent this progression, to prevent these phenotypes, which, as we have seen, are caused by different mechanisms. We can make a good job with primary prevention, with secondary prevention, with optimal treatment of an acute infarction, with an optimal treatment of heart failure. If we fail, we reach the final phenotype. In this case, phenotype and endotype coincide. But as somebody said, life is an incurable disease transmitted by sex.
Thank you, Professor Crea. Please.
Giovanni Viegi, CNR, Pisa and Palermo. I'd like to ask you something about air pollution, because in December, Environmental European Agency issued a report stating that 60,000 premature deaths occur in Italy due to particulate air pollution. A recent European initiative, AFECOM, calculated that for over 65 years old people in Europe, we can estimate 20% of population attributable risk due to air pollution for ischemic heart disease. I haven't seen the air pollution in the list of the risk, and I would like to ask you whether the cardiologists at the individual level or also at the public health advocacy level are taking this important risk factor.
Well, thank you for your important question. You have noticed that known risk factors explain 90% of myocardial infarction. So still there is at least 10% of infarctions which has to be explained. And I'm sure that this 10 remaining percent in part or entirely may be related to air pollution. So this is a very important topic. We do not explain all infarctions with our risk factors, and this can be an important additional factor. You are right, as cardiologists, we are less sensitive than you are to this issue. So perhaps it's another field in which we should cooperate in the interest of our patients. But I agree with you, it's an important issue for us as well.
Professor Fabbri.
Thank you, Filippo. You mentioned and Jerry mentioned one very relevant issue that very often we have simultaneous atrial fibrillation, ischemic heart disease with PCI done, heart failure, and some neurological vascular problem. It's a quite common phenotype. So it's your multimorbidity as we consider our multimorbidity in COPD. You showed us a very nice algorithm, according to risk, how to progress. Now, I know that is not an easy question, but for us, when we sit down and we try to release guidelines for this complex patient, we say, treat the concomitant disease in the patient with COPD like you treat it in the patient without COPD. My question to you is, in this complex patient, do you have this kind of recommendation, or do you have at least some preliminary studies that address simultaneously this complexity? I'm pretty sure that you have it in because you showed the risk factor, hypertension, ischemic heart disease, heart failure. Do you have any recommendation specific for that, or do you have any trials ongoing in this complex patient?
Leo, this is a fundamental question, and I must admit that at least in our guidelines, generically we say, okay, consider comorbidities, but it's not an issue which is systematically investigated or systematically recommended in our guidelines. And this is why it is so important, your initiative here today and yesterday, because in order to really have a full treatment, a comprehensive treatment of our patients, these interactions are extremely important. It is extremely important to consider teamwork in the treatment of our patients during daily practice. It is important to consider this interaction more in depth in our guidelines. I think that it is a change of attitude. So far, medicine has been more and more focused on details. Each of us tends to be focused in details. Now we have to put all together. And as the mass of knowledge is massive, it is impossible for each of us to be really competent in everything. This is why teamwork will be, I'm sure, more and more important. At least in cardiology, it's already very important. Every morning in my institution, and I don't think this is the practice everywhere, but at least in my institution, every morning at 8 o'clock, we have the R team with surgeons, cardiac surgeons, interventional cardiologists, electrophysiologists, experts in imaging, geriatrician, and psychologists. We meet every morning to discuss complex cases. In this setting, more and more, we will need the pneumologist or the expert in chronic inflammatory disease and so on and so forth. It's a change of attitude. This beautiful meeting you have organized, among the other advantages, gives a strong stimulus in this direction.
There's another question.
Yeah, thank you for your lecture. It was beautiful. As you heard, we pulmonologists are constantly concerned about the heart. And I guess you touched a little bit on this, but you know, you did not mention the lungs at all in here. That I don't take it as an offense, but but my question is, obviously there is an interaction, there is a multimorbidity, the heart and the lung, you know, as you heard, you know, they are together as far as we are concerned. What is your thought? I mean, how much you worried about the COPD, about the lung disease when you are, you cardiologists, you personally, you are looking at the patient that you are looking at?
Well, of course, I didn't dare to invade your field. I am here to listen to. But I'm specialized in pneumology. I specialized with Carlo Giundini long ago. So I know the field perhaps better than other cardiologists. But what I do in daily clinical practice is to pay a lot of attention to pulmonary disease, and I think that in the organization of the hospital, the creation of a cardiothorax center is very important. This is something we have organized in our hospital recently, but I think this is the way forward to have cardiothoracic departments where these interactions are facilitated. So definitely in our daily practice, we, at least I tend to pay attention to these important interactions, but I think that more we have to do in terms of organizing joint meetings, joint guidelines, and a daily activity where the heart team, the extended heart team in our case, plays the critical role in discussing complex patients, which are the rule every day. Every day, at least 50 to 70% of our patients are more than 80. We are living with an aging population, fortunately also looking at our future. But this is the current problems we face, and the teamwork approach is the key to provide the best treatments to our patients.
There is a last question.
Carubi, Modena. Thank you very much for your presentation. I think that nutrition should also be taken into account. Nutritional evaluation and treatment is getting more and more important for all of these patients, both in prevention when you have the metabolic syndrome, but I would like to see it enlisted also when you have a heart failure and COPD, because nutritional treatment has been shown to be very useful to avoid and prevent relapses. Thank you.
I fully agree with you, and indeed, irregular consumption of vegetable and fish is a potent risk factor. It's one of the 8 risk factors which are relevant for ischemic heart disease. And also recently in the New England, our Greek colleagues have published a very interesting study where patients were randomized to Mediterranean diet and conventional diet with associated to a reduction of ischemic, of cardiovascular events. So this is a very important issue. I think that anyway, we have to keep this thing simple and clear. Eventually, what matters are 2 things: weight, with some complications we discussed yesterday, but definitely abdominal obesity is a negative phenotype, and also quality of diet, where the key issue is to have is positive more than negative, not to avoid, but it's better to have vegetable and fish every day on the table. This is what seems to reduce cardiovascular risk. Yeah, this is another phenotype for a more advanced stage of disease, but in primary prevention, definitely we should give, in my opinion, a simple message: keep vegetable and fish on your table, do not gain weight, and physical exercise is the other important issue with regard to daily life.
Thank you very much, Professor Crea, for the lecture and the discussion.